Dr. Asmita Hossain. Today I'll be presenting a 7-year review of radical nephrectomy, robotic assisted versus laparoscopic at Surrey Hospital. The radical nephrectomy remains the gold standard for large or locally advanced renal tumors. With incidental detection of renal cancer rising, the number of nephrectomies has also increased. Now, the debate is whether robotic approaches offer clear benefits over standard laparoscopy. The robotic platforms have revolutionized urology. At our center, we have mainly used a CMA VASIS system. The Da Vinci and Hugo system has also increased popularity within NHS. So our objective was simple: to compare robotic and laparoscopic radical nephrectomy at our hospital, focusing on perioperative outcomes, complications, oncological safety, and treatment timelines. So it was a retrospective review of 113 patients from 2018 to 2024. We have compared 50 robotic cases and 63 laparoscopic cases. The data collected included demographics, renal functions, TNN staging, operative outcomes, complications, and margin status with the POSUM risk scores. Let's come to the result. So both of the groups were well matched. Mean age was mid-60s and the gender split was similar. Renal function preoperatively was also comparable, which gave us a balanced baseline. The most of the cases were incidental findings, about half with the hematuria and pain making up the rest. Robotic surgery tended to be chosen for more advanced disease, which is important when interpreting the outcomes. Here you can see the TNN staging. The robotic cases often involved T3 disease or nodal involvement, meaning higher complexity, where laparoscopic cases tended to be earlier stage. National trending. The robotic adoption has been growing steadily. At our hospital, the shift was dramatic, from 0% robotic in 2018 to 2019 to 70% by 2024. This reflects investment in robotic platforms and surgeon trainings, and we'd like to hugely thank two of our robotic consultants who are continuously contributing to the robotic platforms. Robotic cases took longer, about 4 hours versus over 3 hours laparoscopically. It can be due to the docking or case complexity, but despite of longer time, the blood loss, transfusion, and complication were similar between the groups. Both of the groups had a similar complication profiles, most being low grade. The ICU admission were rare and comparable. The margin positivity was slightly lower in the robotic cases, which may reflect some better precision. The POSUM scoring showed a slightly higher predicted morbidity and mortality in the robotic group. This may also reflect the greater complexity. Some of the cases at our hospital exceeded national 62 days cancer pathway target. About the length of the hospital stay, robotic had a slightly shorter hospital stay, about 3.6 days versus 4.2 days, but it wasn't statistically significant. Meta-analysis and large series show similar perioperative outcomes between robotic and laparoscopic nephrectomy, with robotic trending toward fewer complications but at higher cost and longer operative outcomes. Our findings align well with this evidence. So, to conclude, the robotic nephrectomy is safe and effective with comparable outcomes to laparoscopic surgery. It seems especially useful in more complex cases where precision and ergonomics can benefit the surgeon. The future work should expand to partial nephrectomy and multi-center audits. We have recommended wider access to robotics, continued data collection, and multi-center collaboration to build longer-term evidence. Ultimately, both approaches remain valid, but robotics is increasingly preferred for complex disease.